our speaker, Shelley, who spoke this year at the National Academy.
You're having trouble today.
Yeah, I'm having a lot of trouble today at the Society of Addiction Medicine, and gave a wonderful talk there. And we've had a couple of talks from that big conference, and they've been just amazing. So the announcements now, again, she's going to talk a little bit about evidence-based treatment in correctional settings. She is a lawyer. She is not a doctor, lawyer. And so we love having lawyers on sometimes. Next slide.
So big flashing lights. If you haven't registered for the new iEcho platform, please, please, please do so, because the current Zoom link that Katie has dispersed in the past will no longer work to get on Echo. So last chance, please register for your iEcho account. If you have questions, please reach out to Katie, as she is the wizard of all things Echo.
And I registered for this in 1 minute and 30 seconds. So it is possible. Next slide. So some upcoming talks. Bounce Back apparently got on our schedule. You got that one kind of going. So we have, and that's about a community health and wellness specialist who does a lot of stuff with addiction. And then we have somebody talking about hepatitis. So a lot of great talks coming. And of course, we're coming into the holidays, so we're going to take a bit of a break, but lots of stuff coming.
So there is free CME offered with these sessions. We do ask, however, that you keep your cameras turned on. We don't care if you're eating lunch at all. We just like to see your faces. Keeps things interesting and fun.
Unless you're doing something really distracting like juggling. We wouldn't want that. Next slide. And again, if you need any technical assistance, please call us. And you can email us, you can find us, and if you have difficult patients, you can sure ask us some questions to help you.
Stratus Home is the home. Stratus Health. I'm having trouble today too. Holy moly. It's just one of those days. Stratus Health has a core website, which has a lot of really nicely laid out resources for anything opioid or addiction related. So check it out if you haven't.
All right. And now to just one quick thing before we get to our speaker. One of my favorite people, Dr. Gregory Amer, is on today. And he was the first buprenorphine prescriber in Minnesota. And when I was trying to figure out how to do this in rural Minnesota, I Googled and found Dr. Amer, and he was gracious enough to take our team in and teach us how to do this. I think in reality, everything that has come from that with our community programs, our ECHO, the hundreds and thousands of patients that have been taken care of by all of you, were, I think, a lot due to Dr. Amer's work with students and people like myself who really needed to learn this. And he's retiring. And so I thought we'd have him on and let him say a couple of words. And we just wanted to tell him how much we really appreciated what he did during his career.
Yeah, thanks, Kurt. Can you hear me?
We sure can.
Yeah. Next Thursday, a week from tomorrow, will be my last day after about 49 years of going to the same parking lot every day. But yeah, it's been a wonderful career, profession, doing family medicine, and then being medical director of the treatment programs for over 30 years, and developing all the detox protocols, and then finally ending up with just seeing my own addiction medicine patients in the clinic for ongoing care. It's been a great way to start and build up and then now wean down.
Yeah, and I'll have to tell you, you've sent a few patients up to us in St. Cloud that you were seeing, and I hope I can live up to the expectations. I think them having worked with you for so long, I don't know, I feel like I'm I'll see if I'm up to the task. We'll see.
Well, I'm sending you good patients. They're doing really well.
Well, again, thanks, Dr. Amer. And again, have a wonderful retirement. Just so much appreciate all the work you've done for our state.
Yeah, and appreciate you for getting involved in this and keeping it going.
All right. Well, thank you.
Okay.
All right. Take care. All right. So now we will move on to our speaker, Shelley Wiseman. And again, I saw her talk from the American Society of Addiction Medicine. I got it that time. And it was just really intriguing. We've had a couple of different physicians and lawyers on from that conference, and we're going to continue to have others from that conference, trying to bring them to Midwest, the United States, to kind of spread the dated stuff. So Shelley, if you want to introduce yourself a little bit, kind of tell a little bit about what you're going to speak about, and again, we appreciate your time to speak to our group.
Great. Thank you so much. Thanks for inviting me to speak. It's really nice to see everybody's faces. It's nice to be like on a call where I get to see people rather than just like talking at a screen. So this is great. I'm going to go ahead and share my PowerPoint. Can you remind me, Kurt and Aaron, how long you'd like me to speak for?
Yeah, typically you have about 45 minutes for questions, and I would expect with your topic, we'll probably get some questions. So
okay.
I certainly had questions after I heard your talk at ASAM. So yeah, about that time.
Great. Sounds good. Right. Let's share. Okay. Just get a little organized here. So a little bit about me. My name is Shelley Wiseman. I am an attorney, as mentioned, and I'm also an adjunct professor at Georgetown. I teach a class at Georgetown Law School, and also in our Master of Science in Addiction Policy and Practice program. I teach a class called Addiction and Mental Health Law and Policy, which is like a labor of love, and seeing students come through that are just, on fire about these issues is one of the things that keeps me going in this work. I've been at the O'Neill Institute for about 5 years almost, and O'Neill it's like a health policy think tank at the Law Center. There are global health projects and domestic health policy projects, and I work on one of the 3 domestic health policy projects focused on substance use disorder policy. And the idea of our work is to take science and evidence and translate it into actionable public policy for policymakers. So we do things like draft model state legislation. We do talks like this. We work with ASAM and other organizations around the country to move the dial on embedding research and evidence-based strategies into the fabric of the law. I think, as we all know, sometimes the law gets in the way of or adds barriers to good practice. And so that's the focus of our work. We're on the Hill where we work with states. So we do a lot of that type of work. And I came to Georgetown from working in state government in New York. I worked in the governor's office overseeing New York's kind of policy and operations related to substance use disorder, mental health, and disabilities, including the delivery of behavioral health services in New York's prison system, which is related to what I'm going to talk about today. Before I worked in state government, I also did a lot of work at the State Office of Mental Health with the Medicaid program. And so that's one of the lenses that I bring to this talk, as you'll see. And before that, I worked in legal services, suing the state about access to care. And then I went to work there. So I got to see all coin, the proverbial coin, right? So that's my professional history. Personally, I'm a person in long-term recovery from a substance use disorder for over 25 years now. That's me. That's my husband. That's my baby, Jack. And I show you this and I say this for many reasons. One is, we're going to talk a lot about data and statistics and numbers and deaths and all this kind of stuff today. And, I just wanted to remind everybody, and I know people have patients and family members, and maybe you yourself have traveled this journey, but just to kind of remind everyone, there's hope out there. Like, we're doing this for a reason, and one of those reasons, Colonel in the Army, little Jack, and I'm just, bebopping, doing this life in recovery, and recovery is possible and it's beautiful. And part of my interest and dedication to this work is so everybody can have the chance that I had to not just to live, but to thrive. So that's us. All right, now on to some of the numbers. And I'm not going to read slides to you guys, and I'm happy to share this with everybody. But, one of the main focuses of our work at Georgetown is this intersection of public health and the criminal legal system. And we focus on this for a number of reasons. We're in a real, epic time in our history of what's happening with mortality. Even before COVID, life expectancy has been on the decline. Alcohol-related deaths are included in that, 140,000 plus a year. Suicides, often related to substance use. So I'm not just going to talk about opioid use disorder in this presentation. And then, of course, overdose, we all know the numbers, almost 110,000 a year. So we're really in a crisis, right? And we've been in one. I don't even know if you can call it a crisis because it's not like short term anymore. But what we see is that many of the things that we've been doing to address this, some are working, some are not working. And even if some of the things did work in the past, they're not working anymore. So, this is why we focus on this work. And I'm just going to, put text. I grew up in Texas. Apologies. This is Cowboys, where the Cowboys play. When I started doing this presentation, I don't know, about 5 years ago, this was the number of overdose deaths in a year. This is about 85,000. We're like at 110 almost now. So the amount of people we're talking about can't even fit into this football stadium, and of course everybody remembers this is your brain on drugs, and of course I think we're probably more in this type of a situation now, kitchen fire, or maybe the whole house is on fire, right? So I'm going to kind of blow through some of these because I think you all know the statistics. Fentanyl, et cetera, is really causing us to spiral out. And what we know is approximately, I think the numbers are a little bit better now, but still pretty low, approximately about 10% of people who need help get treatment. And is it even evidence-based treatment? Sometimes, not always. And then, of course, we have this increasing number of people in our jails and prisons for drug offenses or drug-related issues and alcohol. So, we're really seeing this kind of challenge today that's been going on and is still going on, where people who need treatment don't get it. Where do they end up? In jails and prisons very often. So that's why we don't only focus our work on this, but this is one kind of targeted space where we're looking at the landscape of public policy and reform and where can we make the biggest impact. And corrections is a big one. And we're talking about before people even go to jail. There could be a whole separate presentation on diversion and deflection. We're also talking, can talk about after people get out of jail, reentry, and services and supports needed there, and probation and parole. So, the whole kind of span of people involved in the carceral system or in the criminal legal system, the criminal justice system, whatever you want to call it, that is a place where we can really, really target action. So this isn't even just about overdose, these numbers that I'm about to talk about. These are about deaths in jails related to drug and alcohol intoxication. Huge increase from when this really, from the last 20 years, basically over 20 years, quadrupled. And most of the people that die in jail, say most, almost half of the people that die in jail related to drug and alcohol intoxication were held for less than a week, often 24 hours. So it's just something to think about when we think about where do we need to target our scarce resources, time and energy. When people die in a carceral setting, it's often like right away. So I don't know, if everyone can think about, if you work in jails and prisons, if that's part of your practice, when do people usually see a clinician? Is it within the first 24 hours? Not always. Sometimes people don't get to see somebody for a week or more. And there are many reasons for that. But what the data shows us is that when we look at when the deaths occur, it's like right away. So a seed I'm planting to think about where we need to kind of push scarce resources, right? And then, of course, on reentry, the second paragraph here is about how incarcerated persons are between 10 and 40 times more likely to die of an opioid-involved overdose. And it's really about the 2 weeks after release, the first 2 weeks after release. So, it's difficult, right, to kind of move a ship that's large, that's bureaucratic, that maybe this is the way things have been done for years and decades, but this is what the data shows us, is these are the timeframes that are really, really critical to focus on. Right away when someone walks in the door to a correctional facility, and then the first 2 weeks after. And then, of course, there are certainly collateral consequences of incarceration, and that's also part of why we focus on this. And we're not going to get into all that today in great detail. Obviously, there's a human cost here. These are just 3 examples, and we did a pretty exhaustive research study not long ago where we looked at a 5-year period of time, 2015 to 2020. So this didn't include COVID. And we looked at where were jails and prisons getting sued for deaths behind the walls. And I'm going to get into some of our findings, but these are some of the faces of the findings, right? And some of the payouts that had to happen when people died in jail. So we actually just finally got this paper published, and we have a brief that outlines it as well, and happy to share that. Also at the end of this presentation is like about 3 to 4 slides of just links and resources. So everything that I'm referring to, I tried to put it in the back. So here's what we found in our research, is that almost $300 million was paid out for civil litigation cases involving deaths in custody. Most of them were settlements. Some of them were judgments by a judge or a jury. Suicide was the leading cause of death, about over a third of the cases that we reviewed. And drug-related deaths were 19% of the lawsuits. And just over 84 million of the payouts were for lawsuits involving drug withdrawal, overdose, and substances. And the litigation in this space tracks the Bureau of Justice Statistics data. So the kind of percentage of people that die in jail for the reasons we're talking about here tracks the roughly the percentage of litigation that's brought as well. I think there's a few more things I wanted to say actually about those lawsuits.
Just one question. I hate to interrupt you, but do you think that in your research has fentanyl changed this at all? Heroin was kind of a different animal.
Yeah, I mean, this is 5 years, 2015 to 2020. Now we have a situation where there's almost no heroin left in the drug supply in many states. It's just fentanyl. I think it's an interesting question what the impact has been on corrections. I don't, have and litigation. I don't really have the research about that. I will say kind of, and again, lawyer, not clinical person, but from a clinical perspective, I think people have had to meet the need and treat in different ways because of the potency of fentanyl. And so, that just makes the imperative to provide treatment in correctional settings all the higher. I don't think in the past few years we've seen like this sea change of people just not getting incarcerated. I think in some counties have done really tremendous work in some states on deflection, on things like that. But all in all, we're seeing it's an increase. We're seeing an increase of deaths in jails, not a decrease. And so I don't think we're seeing kind of everybody's just not going to jail anymore. We're seeing that in some jails that are providing medications for opioid use disorder, and we'll talk about it. Like in Albany County in New York, where I lived for 5 years, the sheriff there began implementing with a whole coalition medications for opioid use disorder, methadone, buprenorphine, coupled with a lot of other kind of social and clinical supports. And they had to decommission 100 jail cells because people just stopped coming back to jail. It was the same people cycling in and out, in and out. And when they began treating people behind the walls, people just stopped coming back. They stopped offending, or, their involvement in the correctional system just ended. So, that's why we're kind of very focused on this topic in particular, not just because it's evidence-based practice or it's clinical best practice, but because it saves money, it saves lives, it saves communities. This is, I think, one of the ways that we're going to start to shift this. Is it starts with getting people treated while they're in jail. I don't know if that fully answered the question, but so, we talk about saving money. Huge economic cost, right, to this crisis. And jails are expensive, and providing healthcare in jails is expensive. Much cheaper to not have to do it in a jail. So something to think about there. Okay. So, from a kind of national policy perspective, and I think in a lot of states too, sorry, it's very cold in the room I'm in right now. I'm going to put on a little coat, you guys. I'm in North Carolina. I'm not even up where y'all are, and I'm cold. All right. So, in general, the landscape is moving from a punitive approach towards a public health approach, right? That's in general. And we can get down to specifics about what that means and what it's going to take to accelerate that. Litigation, that's lawsuits, legislation, primarily at the state level, and policy guidance are all vehicles for reform. I can tell a little story about when I was working in the governor's office in New York. And one of the first lawsuits about, I think it was, I don't remember if it was methadone or buprenorphine, but about treatment in jails in Massachusetts happened. And we all said to ourselves, oh man, we got to get on this because we are next. And the lawsuits, and New York is one of the states that's having lawsuits, and many others. And those, now New York has a law requiring access to these medications. And that's, the role of litigation in policy reform sometimes can be slow, but sometimes it can really motivate. And then there's also a movement, which I hope will get to be a quicker movement, about a focus on building recovery capitals, kind of social determinants of health. So yes, it's great to ensure people have access to clinical treatment, to medication, to evidence-based treatment, but then what, right? Like people have their whole rest of their lives to have to live. And, I talk about often that there's a women's kind of sober living or recovery residence down the street from here, from where I live. Every woman there has access to buprenorphine. They're mostly in treatment, but they've all got kids. They've all got child protective involvement. They've got abusive exes. They've got trauma. They don't have anywhere to live. They don't have anywhere to work. So there's a real movement now, I think, starting to think about, okay, like access to treatment, great, but we also have to help people to like get their lives back or build a life. So, again, we talked a little bit about why we focus on this. And of course, this is a high risk group. But it's also a very separate siloed system traditionally. We have advances that are being made in treatment, in medicine, but it doesn't get reflected in the corrections or court systems as quickly. And so that's, one point of focusing on this is to kind of bring all the systems along that might be siloed or outside of the traditional system where people get treatment. And this is a key intervention point. Someone is in jail. That is a time for maybe, a window of willingness to take a look at things and do something different. This is a quote here from Sheriff Apple in Albany that I mentioned. So when I first met him, he said, "No way, we're not doing Suboxone or methadone. We get that diverted. I mean, we get it's, people sneak it in here. It's, we're not doing that." And less than a year later, he was convinced to do it. And this is what he said. He said, "I didn't believe in it, but we were convinced to try it. In the first 3 months, we saw a reduction in diversion and recidivism, and it was saving lives. It's a no-brainer." I mean, this is a guy who was like, "Nope, not going to have it in my jail." And it was some advocacy that convinced him. And I think the science that convinced him. And this is the jail where I said they decommissioned 100 cells, and they actually turned those jail cells into temporary housing for people, where they are connected with social support, with employment support. And we're talking about Albany. They have the same kind of winters you guys have, and it's not a great place for 8 months of the year to not have somewhere to live. And so, they're really doing some great work over there. So what is involved in a public health approach? We're talking about immediate access to treatment, not when it's your time to get off a waiting list. There's another advocate who talks about how there's no waiting list for jail. And that always really stuck with me, right? There's no waiting list for jail. We find a way, right? And so, same thing should be applicable to treatment, low barrier treatment. Access to evidence-based treatment, that's medications for opioid use disorder, methadone and buprenorphine. Those are the medications that have been shown to reduce overdose. And I can say this, I went through 3 years of treatment and, big believer in therapy, all this stuff that we need to help us, right? But when it comes to reducing overdose, the research shows it's not that. It's not long-term treatment. It's not detox. It's not therapy. It's medication, methadone and buprenorphine. That is what reduces overdose. That is the only thing. All those things I think are great for helping people to get their life back, and learn to be a person in the world again, right? But when we're talking about overdose prevention, it is those 2 medications. Family-friendly treatment with wraparound and long-term support, diversion, deflection, withdrawal management in jails that is based in, again, the clinical best practice. And we're talking about withdrawal for alcohol and other substances. Okay, so here's the study that I talked about, methadone, buprenorphine only. And then, of course, on the other end of the coin, when people get out of correctional settings, it's the people that are having access to medications that don't die. Methadone, buprenorphine. So over and over, many, many studies are showing us 75% less likely to die, 85% less likely to die. I mean, the numbers are pretty staggering. I mean, the answer is very clear. We talked a little bit about the lawsuits. There are many of them out there now. A number have been settled. The U.S. Department of Justice has gotten involved. These are lawsuits about access to medications for opioid use disorder, methadone and buprenorphine in correctional settings, in nursing homes, in recovery housing, in other types in the court system, right? And then you also have other types of lawsuits about people dying behind the walls, which we talked a little bit about our research. The Department of Justice bringing litigation under CRIPA, the Civil Rights of Institutionalized Persons Act, and others. We actually have a publication where we look at all 50 states and what we could find of what is the current state of access to these medications, whether there's legislation in that state, whether there have been lawsuits or different policies that are being implemented. And in a lot of states, it's one jail kind of out there doing a pilot. They got some money and they're seeing some great results. And then the state follows with a broader initiative. Other of the state and national policy reforms under discussion. The one big item for discussion is about Medicaid being able to be provided in when somebody is incarcerated. Right now, Medicaid will not pay for somebody healthcare if they are incarcerated. So there are a number of bills in Congress right now to either change that incrementally or completely. There are also reforms at the state level through state Medicaid waivers, 1115 waivers, to give access prior to release to Medicaid. A number of reforms for methadone access under discussion. There was guidance issued by the Department of Justice about the Americans with Disabilities Act. And the guidance said this: it is a violation of the Americans with Disabilities Act for a jail or a prison to say, no, we don't provide methadone or buprenorphine as a policy. So we're seeing, again, more litigation on that. State legislation we talked about, and then parity implementation. That's another big piece that I could do a whole other presentation about, but I won't. Here, this little square picture is a picture of a model state legislation that we drafted with a bunch of experts about access to evidence-based treatment in correctional settings. We also have model state legislation about withdrawal management. This slide is about the Americans with Disabilities Act guidance. And the Justice Department has started acting on this guidance and bringing lawsuits. Okay, so how do we do this? That's a big question. It's a big change. And how do we pay for it? That's the other big question. I'm just going to go through some guides and toolkits that are out there, shared learning opportunities like this one, technical assistance that's available, and some funding. So guides and toolkits from the National Sheriff's Association to SAMHSA, courses about how to do this in a correctional setting, like step-by-step policies needed, who needs to be on board, what are the, all the pieces of the puzzle. And these are just 3 examples. Actually, the Bureau of Justice Assistance just came out with some more materials about withdrawal. There are shared learning opportunities. The Opioid Response Network is a free resource that is funded by the federal government and SAMHSA to provide technical assistance to anyone who wants to do this. There are also local funding opportunities, like the California Health Care Foundation, for example, funded a whole collaborative that involved moving this into jails and prisons in the state of California. And we've got some resources on our website too. There are a number of organizations doing technical assistance on this. Obviously, engaging key partners is very critical. A lot of jails have, a third-party healthcare vendor that needs to be involved, and there are contracts there with that. And a lot of what I've seen is that this is about a culture shift, and really getting everybody on board with what this is, why it's important, and what to do. Lots of funding out there for this, for anyone looking to either start a program or keep it going or grow it. Starting with the block grant and SOAR money to Bureau of Justice Assistance has specific funding for these types of initiatives. And then, of course, there's opioid settlement funds. In Minnesota, for example, you have 75% of opioid settlement funds going to local government, and that's who runs jails. So there's a tremendous opportunity there to use opioid settlement funds to support something like this. And there's specifically in the agreement in Minnesota between the state and the counties about how this money is going to be spent, and a whole section that talks about prioritizing justice-involved persons, and specifies medications for opioid use disorder during incarceration. So I encourage folks to kind of figure out what's going on in your county, and maybe this could be a use for that. Here are all the resources I talked about. There are others. Oh, and that's baby Sammy, just to bring it back. That's our second one that was just born 6 months ago. So, who doesn't love to see a baby in a pumpkin? And we're just out here doing this. So I don't think that was 40 minutes, but I'll end there. And, I can talk more about our research, more about what the law says. I don't know where people want to kind of go with this. Here to answer questions.
Yeah, I mean, if we want to open it up first, if there's anybody has specific questions, if you want to just unmute or type them in, that's fine. I know that Aaron and I have a couple as well.
I think it's safe to say that you have the cutest babies on the planet.
Oh, thank you. I think they're pretty cute.
The bow tie on the one, I don't know. That seemed like overkill.
No way.
So anybody that has any specific questions they want to start with?
Can we get to links to the resources mentioned in the slideshow? Yes, absolutely. So we can get those. We post the recordings on our core website, I believe, and Katie will be able to help with getting the recordings and the didactic.
Shelley, has there been a certain push in certain parts of the country more than others? Is it the coasts where this has been much more common, or central? Where has it been more active?
I think and this is the story of every innovation. I mean, this is the story of emergency department, for example. It's where there's a physician or clinician or a sheriff or some champion that decides, all right, enough already. We're going to do this. And they're in a position of leadership, in a position to move things. It could be a governor. It could be a chief justice. It could be an ED physician, or the doctor in the jail or whatever. It's like, all right, I'm going to take it upon myself to do this. And it starts small. And they find money and they start seeing results. And then it turns into just how we do things. That's where we're seeing it happen. It's from Arizona, Minnesota too. Here in North Carolina, where I live, There's some momentum. So it's pockets.
Yeah.
Where there's a champion. That's where we're seeing it.
Are you seeing much more Suboxone than methadone?
Yes, I think so. It's just easier, frankly, with some onerous federal regulatory and sometimes state regulatory barriers. But we are seeing methadone. And again, it's usually I'm going to cut through this bureaucratic, whatever you want to call it, I'm not going to say it here, and make this happen, and just making it a mission. And I think with fentanyl, we're really seeing, access to methadone is really, really critical. There's also new opportunities for mobile methadone, which is an opportunity for innovation there, in partnering with an opioid treatment program that can bring a van, don't have to necessarily have all the bells and whistles on site.
I absolutely speak about the jail that made 100 of their cells into housing. I think that's just absolutely amazing. And what a neat way to use that space and really, really show the productivity of their program.
How many studies have you seen about recidivism in places where they do MOUD in the jail as opposed to not? I mean, are there any great studies for that?
What I have, the studies I've seen, one is out of Arizona, and it's with methadone they have like one facility there where people who violated parole go. And so it's about methadone in that facility. And not only is there pretty significant data around the reduction in recidivism, but the increase in employment is also there, and other types of social determinants as well. So I wish someone would do a kind of a comprehensive study. There might be out there. I can ask some of my research colleagues.
Perfect.
Wonderful. I know it wasn't, kosher for a research study, but we kind of looked at patient population in a small rural county in Minnesota. And it showed that prior to being in a buprenorphine program, the average jail stay or day spent incarcerated was like 56 or something like that.
80.
80. Okay.
Mm-hmm.
Katie would probably be able to speak to this better. She's the numbers gal. But then post being in a MOUD program, it's like 5 point something. So it's just amazing how much time spent in jails decreases.
Yeah, that was a kind of an extensive look back. Took a lot of time to look back through all the DOC records for the last 5 years and then the years beyond that. But yeah, it's a pretty substantial difference. And it wasn't like a huge, didn't make it like a huge study. It was just more kind of the data we were using for a state program.
Mm-hmm.
So it was just very interesting that we saw that recidivism really change in that way. So,
and some of the days that were captured after starting a mood program were actually folks serving on old charges.
Mm-hmm.
So it was, even less than that realistically. So it just shows such a huge impact.
All right. Other questions?
Yeah, Kurt, I've got one. Shelley, for a great presentation. Tim Stratton up here in Duluth. I'm in the College of Pharmacy and have worked with a rural county jail on this issue pre-COVID. And my question is around working with rural jails. Our Board of Pharmacy in particular is very concerned about drug security in the jail setting. And many of our rural jails look at what they would need to do to provide that infrastructure, and they just throw their hands up. And so nothing happens. I'm wondering what your experience has been working with maybe some of the more rural counties.
So what I have seen is you need a few things. One, a champion. Again, someone who is like going to commit to it at a high enough level. So then there's not going to be the throwing up of hands, right? Because that's key. And then 2 is technical assistance, getting somebody in who can kind of walk them through, here's what we do, and then help them to accomplish it. Sometimes it needs to be a partnership with the state, for the state to take a look at the regulatory structure that exists. And maybe there are some, I don't know about Minnesota, but maybe there are some state regulations that can be kind of tweaked or modified or waived in certain circumstances. And really kind of be a partnership there to say, hey, how can, the goal is to make this happen, and getting the right people around the table in order to do that. And there is specific grant funding to do that. Specific grant funding for technical assistance, specific grant funding for the kind of coalition building that's required to really be successful. And I think specific focusing, there are grants that specifically focus on rural jails and how to handle the kind of challenges that might arise. And some of it also that I've seen is about starting small, not kind of biting off a giant bite, but really looking at like, okay, what's our 4-year plan or 5-year plan here? And let's start small incrementally and then kind of let it grow organically. That's the other thing that we've seen be successful in a rural setting.
Yeah. And I would just comment on that too, that, the infrastructure, I think, is different if you're doing methadone, obviously, than buprenorphine. I think when we look, and having worked in the correctional system for a year, that if there's diversion of buprenorphine, there's typically not consequences, right? People don't overdose and die on buprenorphine in a jail. But if they're not on it and they leave the jail, they overdose and die. And you've seen those figures. So the methadone, as far as diversion and stuff, to me, yeah, that's a much bigger issue. And the safety of that and how we lock that up and all those things is a big, that's a big barrier. So, yeah.
Right.
I think just following practices that you would with any controlled substance in a correctional facility, if you're stocking buprenorphine and taking it out of an e-kit, just making sure that that's all documented and that medication is being counted at each shift change. Locking it in a med room or in a med cart, so it's double locked and following DOC compliance, things like that. It's just all about communicating. If you have officers doing some of your medication passes, that they communicate with medical to make sure that everyone knows that counts are correct, or how to count for that matter. And just following practices like you would for any other controlled substance, because it's really no different.
Yeah.
Looks like I'll just add that the good news about the fact that this has started in a number of jails now around the country is that we don't have to reinvent the wheel. There's a model for this. Yes, every jail is different and the makeup of, who the staff is, et cetera. But there's, a few different formulas to choose from, basically, about how to get it done and then tweak as you go. A lot of good learning from other facilities that are doing it.
Yeah. Looks like Dave has a question, and then Tara Holt from the state has a question. So go ahead, Dave.
Well, it's kind of a survey question. I've had 2 patients referred to me from the Department of Corrections from the state if I would follow people after they got out of prison. And I said, yes. It has not been an outstanding experience, and neither of them are in my practice. But I was just curious. So at least the state prisons are thinking ahead, like, can we get somebody connected up when they get out? I'm just curious if other people have had any similar experiences.
Yeah, I've actually had probably a half a dozen from the prison system, and I would say half would have done okay, roughly. It's interesting because, if you look at even just coming from a jail on buprenorphine, most of the bigger studies show that you get about 60% of people will actually show up and be retained, right? And so I don't know that it's much different, but I think it is a little bit tough sledding coming out of the state prisons. Anybody else have an experience that way? It's just you and I, Dave. And there's Tara Holt from the state. She says a state grant award practice, we have struggled to get the buy-in from the right folks in the jails and typically end up having to reallocate the dollars that we had for those services. Any tips?
Yeah, it's a great question. And I can put my former state official hat on and say, sometimes you got to make them. That's what the legislation is about. If there's a requirement, a mandate, well, that's that. You know, if the money, it's like, what's the right mix of carrots and sticks in your state, right? In one state, having some extra money to do some stuff they've been wanting to do might be enough. In another state, it might require more. You know, and it could be a few different ways. It could be in legislation. It could be using the bully pulpit of the commissioner or the governor's office to get out there, or the you know, I don't know. Depends, right? I mean, in depends what the political landscape is, and I'm not going to pretend to put my toe into Michigan politics. But you know, you just have to kind of figure out what the right mix is, and that's why we're seeing state legislation. And even with legislation, it's hard. It's hard. Implementation is a whole other thing. You can have a great, beautiful law, but then the devil's in the details of the implementation. So, you know, it can be a long-term project.
Yep. Good. Other questions? Anybody else or comments? Thanks, Tara, for that. All right. Well, we have one here.
Zach just commented, we have 87 counties and 6 million people compared to New York that has 62 counties and 20 million people. Our jails are small and convoluted, and that state is the one who has to take the lead or create the mandate, in our case here in Minnesota.
It's just my usual rant to the answer. I think somebody asked, 87 counties, 87 different ways of doing things.
Yeah.
It is significant problems. So when we talk about jails in other states, so Shelley, I'm in a jail. We have 187 people here. That's kind of a bigger jail in Minnesota. So and then kind of like Dave's talking with it. So the DOC has a new mandate for the release planning, which is great. But these probation officers and stuff are grasping at straws, trying to find providers in random areas in a county that has a jail population of 17. So again, it's going to have to come from the state, and that's speaking from a former state legislator. So,
yep.
And I apologize. I think I said Michigan and I meant Minnesota. I sincerely apologize. So yeah, we're seeing, like, in another state we worked with that starts with an M, that's in the Northeast, I won't name, they really don't have a lot of providers. The jails in that state, a lot of the jails and the prison system's doing it, and the jails want to do it, but they don't have anywhere to send people after. And so, you know, the other thing we didn't really talk about is this can't be done in a vacuum, right? There's one rural jail in Virginia I visited. They don't have a lot of services in that county. People come, and after they're released from the jail, they come back to the jail to get their dose or get their prescription.
Wow.
So, you know, which is not ideal, but it's what they're doing to kind of cobble things together until more providers can get on board. One other thing we're seeing is telemedicine
status blood test
as a tool, even in New York, where there still aren't enough providers, especially in like the rural areas. So telemedicine has been something that has been an innovative tool for buprenorphine in particular. And that took the state to kind of relax some of the rules around teleprescribing. Now that the federal government has made some of those rule changes that happened during COVID permanent. So it's got to be a partnership, with what's happening at the state level.
Yeah, the interesting thing too, I think that the way our counties work here is the county boards, I think, and there are many of them, correct me if I'm wrong, Zachary, but the county boards often decide this. And as he was saying, unless it was done at the state. And so we've got 87 different county boards. And when we started doing it in a small county jail north of here, we went to the county board to sell it. And they agreed that it was worth a try, right? And so we also had funding to do it. But it's almost like they have to decide because of the cost. Now, we also have a lot of money sitting around now from the opioid settlement. So that is probably going to be less of an issue. But yeah, and somebody just commented about getting people to the right places when they come out of prison. I do think the state has done a great job of that. My experience with the county jails has been relatively good as well. I think we've seen a lot more of that now, where people are reaching out or making sure that follow-up is there, which obviously we all know is so critical. And somebody just commented, I think every county jail is doing something differently. I just lost it.
Okay.
Where'd it go? I was doing something differently. Boy, a lot of people are chatting in and it spun down.
Yep. Okay.
Some are inducting and setting up follow-up, and some are not.
Yep.
Correct.
Okay.
I mean, and I just want to pause and say the fact that there are some jails doing induction, that's huge.
Mhm.
I mean, even look 10 years ago, I mean, we were not in this place, not in this place. So it's good and important to recognize progress and then say, okay, how can we build on that?
Really looking at like cost savings and staff resources if you are doing in custody inductions to really care for people that are in that acute withdrawal phase, that's huge.
Yeah. And in our state, there's some real leaders. If you look at like Hennepin County, their program is just fabulous, and they've done just a great job. Where they run into trouble that we saw in the past was their patients would be put on medication and then sent to a different jail for other charges, and then they showed up, and then what do you do with them? And often in the really rural areas of Minnesota where they had a warrant, they would have to then go through withdrawal from the Suboxone. So although they're doing great, I think, where they are, and they really pull patients right into their system, which I think has been amazing. So I would have to say I really love them, and I love St. Louis County and how much work they've done up in they've really done well.
Yeah, we've actually featured Hennepin County in some of our work. And, the issue you described, I mean, story, right, of people, we have people who maybe they have access in the jail, but then they go up to the prison and they don't have anything, or vice versa, for whatever reason. So, so much of this work is relationships with your counterparts, building coalitions, and kind of saying, all right, we're going to make this work. We're going to make this work. Yes, there's a warrant in this county, but let's have an agreement with that county that if there's no treatment in that jail, then they can serve out their time in this other county or whatever it takes, right? And if sometimes people think they can't do something or that there's a law in place or a rule in place, but it's just the way things have always been done. It's not because they can't do it or have to do it a certain way. So it's really about looking under the hood and seeing, like, why are we doing this in this way? And can we not?
I think one of the interesting things in Minnesota is that the data just came out that the average person would have to drive only 29 miles to find a Suboxone provider. That's how much work has been done, I think, at the ground level with our community programs. Essentia has been very good with this. Centricare has been very good with this. A lot of the bigger systems have really taken this very seriously. And so now, if you look back 5 or 10 years to find a provider, it was for some people 100 to 200 miles coming from the north part of our state. So the access is going to be there. I mean, obviously, this is a work in progress, but there is progress. Anything else that somebody's got? Not any other questions? Anybody wants to unmute and talk? And questions or comments?
While someone's thinking of something, I'm just going to say again, please register for your iEcho account.
Yeah.
You haven't done it yet.
Well, Shelley, I would hope that sometime we could convince you to come back. It sounds like you have other interesting little talks, and we have a lot of rotating speakers that come in once or twice a year and kind of update us on some of the research that's being done. I hate to tell you, I really go fishing at the ASAM meetings, finding some of the best speakers in the country, and you were certainly one of those. And we have another one coming up in a few months. And so appreciate all the work you do on this. I think that's so important, and congratulate you on your recovery. Really, really impressive.
That was excellent. Thank you.
Oh, great. Thank you so much. And, let me know how I can help. And thank you to all of you for the work that you do every day. I mean, it's not easy, not easy work. And it's really appreciated. You're out there changing not just like individual lives, but families and communities, and that person who you help comes into contact with. I mean, it's like a reverberating effect. So it's really, appreciated.
All right. Well, thank you again. And I wish you a great day with those beautiful children. And if there's ever anything we can do for you, please reach out.
Thank you. Thanks, everyone.
All right, everybody, have a good week. We will see you next week. And if there's any questions, please feel free to get hold of us. And if it's about iEcho, again, don't get hold of me, get hold of Katie. She'll fix you. I have no idea.